Assalamu alaikum wa rahmatullah. Thanks for the organizing committee for giving me the opportunity to talk about the early onset scoliosis. As we know, the early onset scoliosis is the heterogeneous and challenging condition. Can be idiopathic, congenital, syndromatic, and the problem in the early onset scoliosis, it really alters the development of the lungs at the alveoli level. So it's not only restrictive lung disease can cause it, actually it hits the lungs in its alveoli structure. And this will affect the daily activity of the child. We always try to go with conservative treatment in early onset scoliosis and delay the need for any surgical intervention. So casting, bracing is effective in delaying the treatment, and always we try to avoid using growing rods until the age of 6, 7 years old. And eventually fusion is become necessary at skeletal maturity. Now, when conservative treatment fails to control these curves, growing rods technique is an effective treatment option. It controls the deformity and allows spinal growth. There is a lot of options of spinal growing rods, and I will not talk about it, but when you have a severe early onset scoliosis, this is where it's the challenge. Growing rods, it's only having an upper fixing point and the lower fixing point, and it will be difficult to control this severe deformity. And the challenge happens more and more when it's accompanied by kyphosis. So, in these cases also the challenge is that the poor nutrition and respiratory dysfunction of these patients. And post-op complication with kyphotic curves increases with the risk of rod fractures, proximal junction kyphosis, or pull out of the screws. So now here it comes the preoperative halo gravity traction helps in treating these difficult early onset scoliosis, especially with kyphosis. And there is a lot of publications talking about the benefit of the preoperative halo gravity traction. So this is a case, a 7-year-old boy with severe kyphotic early onset scoliosis. And what is your feeling when you see such X-rays? Believe me, this is my feeling every time I see such cases, because I know these cases will not stop operating. You'll do the surgery, you do expansions, then they will come with a complication, you have to treat them, and it's a long journey until the skeletal maturity. You have to develop a good relationship with the family. They have to understand from the beginning these are difficult cases. So how to choose these cases which is proper for traction? You have to take a proper history and physical examination. Look for sign of dysmorphic feature, connective tissue disorder like Marfan syndrome, Ehlers-Danlos syndrome, osteogenesis imperfecta, all these, and a proper neurological assessment to rule out myelopathic changes. Then you go for investigation. In X-ray, you do an AP lateral standing films. You measure all the cup angle in the sagittal coronal to look for any congenital anomalies, spinal balance, the pelvic obliquity, and determine the skeletal maturity. And you can add the hand X-rays if the patient reaching the age of 9 or 10 years. CT scan is important to assess the deformity and to rule out any congenital anomalies or fused ribs or fused disc. Check the apical vertebra wedging, check for diastematomyelia, especially the bony bar. MRI is very, very important, and to check for these pathologies like Chiari malformation, syrinx, tethered cord, and check the spinal cord shape classification. This was published by Linke and his group, talking about determining the risk of intraoperative neuromonitoring data loss with thoracic spine deformity correction. And he classified into three types. Type 1 is that the cord at the apical vertebra, there is a CSF fluid running between the pedicle and the cord. Type 2, there is no CSF. And type 3 is actually the cord is compressed and its shape change. So this is very important to assess as a pre-op if you are planning to do a traction for these cases. Because preoperative gravity, halo gravity traction is risky in these cases. When you have a Chiari malformation, C1, C2 instability, the statomyomelia, type 3 spinal cord shape classification, if there is any spinal cord myelopathy, and osteogenesis imperfecta is relatively contraindicated because of the weak bone and the risk of complication from the halo. Now, the traction protocol, you have to use a halo ring with 6, at least from my opinion, 6 pins, and maybe you can add it in 8 pins if a patient is younger than 4 years. You start the weight of the traction with 2 to 3 pounds, according to the tolerance of the child. Then you increase it by 1 to 2 pounds per day. The target weight is maximum 30 to 50% of the body weight, according to the patient tolerance and the correction of the deformity. We always instruct the family and the patient to use the traction for at least 12 to 18 hours per day. When the patient sleeps or in a supine position, we put the bed in a little bit of reverse Trendelenburg position, and we use a little less weights, so to prevent the patient migration proximally on the bed. We noticed that majority of the correction is achieved in the first 4 to 6 weeks. And there is minimal benefit from keeping the traction more than 3 months. So our protocol is 6 to 12 weeks of traction, and that's it. This is the maximum. And usually most of the studies shows that the correction from the halo gravity traction reaches 30 to 40% of the initial deformity. We always encourage the patient to mobilize and do bed exercises to prevent the muscle atrophy. And we have to do daily neurological assessment to make sure there is no ongoing spinal cord injury. So this is our previous patient, and you see the benefit of the traction. It increases the spinal length, it opens the chest, and even the kyphosis get corrected gradually over time. And this is X-rays after 6 weeks of halo gravity traction. And this is his final fixation with the spinal growing rod. And we extended to the cervical spine because of the severe high level of kyphosis to prevent, minimize the risk of BGK in these cases. For take-home messages, halo gravity traction is a safe and efficient treating in severe EOS or early onset scoliosis. It can significantly improve the perioperative pulmonary function and offer great curve correction. Always choose the lower instrumented vertebra to a stable vertebra. Don't go to a touch vertebra or anything. And for the upper instrumented vertebra, go to a stable and lordotic vertebra. Keep in your mind that the risk of BGK and implant failure is high, and this has to be addressed to the family before starting any treatment. This case is complex, and they wouldn't have this curve magnitude and deformity unless they have underlying connective tissue diseases, in my opinion. So and with their growth, usually they will develop a secondary deformity in the future. Thank you very much.
Thank you for